evening, friends. Today we are back with one more important topic to discuss under the surgical courses. And today's topic is liver abscess. I think if you are in surgical training or you're reading for surgical uh, topics, you'll realize that liver abscess, especially in India and other low middle income countries, is a very important entity. And that is why we must know how to treat it. So we're starting with a case. Let's say there's a 42-year-old, otherwise healthy man who presented to the surgery department with right upper abdominal pain and low decay rate fever for 5 days. Patient has a history of regular alcohol consumption, and when you examined, you found little tenderness in the right upper abdomen, and otherwise, the rest of the examination was unremarkable. We did the ultrasound, and ultrasound showed a 5 into 5 centimeter lesion with heterogeneous content. This is the typical description of an abscess cavity, which is in the liver. And now, what to do next? So, in this clinical problem, uh, one, we have to be sure what we are diagnosing, and then how are we managing. So, these are two important parts of this presentation where we'll try to answer these questions: that how to diagnose, how to differentiate amoebic liver abscess from other more lethal kind of liver abscesses like bacterial liver abscess and maybe tubercular liver abscess. And then we'll also try to talk about how to manage a case of liver abscess. Why knowing about amoebic liver abscess or liver abscess as a whole is important? Because it is very common, especially in our country and similar countries like India. So it is very high prevalence rate. On an average, any big tertiary care hospital would be admitting 2 to 3 patients or at least one patient every day on an average. So this is that high in prevalence. Another thing about it is if you treat it in good time, it has a very good and high cure rate. But if you do not treat properly, then there can be high mortality also. So this is one of those diseases where if you treat in time, the outcomes are very good. And but if you don't, then outcomes can be bad. So I think we all pick surgery because we like doing those things, those procedures or interventions, which has a very high impact and high cure rate. And I think this is one such disease. So in this session, we'll try to have an overview of different liver abscesses, differentiating between different liver abscesses, and diagnosing a particular subtype. And then we'll try to work out a treatment strategy of common abscesses, which we see. It's always good to know the history of any disease. And so liver abscess is a very old entity known to the medical and surgical professionals. As early as 4000 BC, there is an account of a disease which sounds similar like liver abscess, which was described by Hippocrates. Uh, Also in 1938, Oshner, uh, for the first time, said that the drainage of this abscess is important to treat. Otherwise, before that, it was all conservative management. Then Macpherson started talking about percutaneous drainage in 1953. And by 1986, I think most of them, they were talking about successful treatment with percutaneous drainage. And so the first major subtype is amoebic liver abscess. So what we will do is we will talk about amoebic liver abscess and then make it as a benchmark and then compare other abscesses with this. So because this is the most common entity which we see. So it is caused by an organism called Enterobius stultica, and up to 50% of the population is infected with. So in our country, you'll see every second person is infected or infested with antiviral, but very few of them will develop symptoms. And 10% of these generally will have clinical symptoms. So 1 out of 5 who is carrying anti-amoeba in gut will develop some disease, some problem. And out of this 10%, only 3 to 9% of will develop amoeba. Most of them will have symptoms like diarrhea and loose stools and some GI disturbance, which is there. Now, overall, if you see right lobe involvement in liver abscess is more common than left lobe because of a very obvious reason. Because if you see the direction or the alignment of the portal vein, the main portal vein is in more continuity with the right portal vein, and the right portal vein is straighter, it is broader, and it is shorter. So most of the antamoeba or the cysts they travel preferentially to the right side, and that is why right lobe is more generally gets more involved in amoebic abscess. So this is in overall life cycle of the antiviral. I'm not going much into it because I'm sure about this, but knowing the earlier stages is important. What happens? So through the portal vein, generally this antiviral enters the liver, starts inciting the tissue response from the body, and it can also travel through lymphatic or transperitoneal, but most common is portal. Now, because of this immune response towards the antiviral, the the host liver cell they uh, destroy the bacteria and there's a neutrophilic infiltrate. And in this process, a lot of liver cells also get damaged. So it forms a mass of necrosed liver cell along with blood, which is generally cauterized, which gives appearance of something like this, which is called as anchovy sauce appearance. Anchovy is a fish, which is and generally it is eaten with sauce, which is anchovy sauce, and the appearance is kind of similar, not exactly similar, but kind of similar. And it's a very peculiar description of this pus. The color and everything, the brownish color, looks like a hemolyzed blood. So that is there. And the good thing about this is not an infected pus. This doesn't have bacteria, many bacteria in most of the cases. If you do a culture, you will find that this is sterile. So, so that is why we'll talk in the treatment. The treatment is slightly different than other abscesses. So this is just a necrosed means of liver cells. So drainage, that is why may not always be required in this case because this is not exactly infected. If we talk about symptoms, most of the patient will present with pain, 90% of them, and fever, nausea, vomiting. These three symptoms are the prominent presenting complaints. They may or may not have anorexia, weight loss, malaise. Some history of diarrhea might be present in few cases, but do not depend on it to clinch the diagnosis. Also, if there's a pulmonary involvement, the patient can have cough or pleuritic pain. Also, rarely, patient can have jaundice with or without in examination, patient generally is cachexic because of the disease also and because of the eating habits. We have to understand that entamoeba histolytica is more common in people who have poor food hygiene or poor food habits, and that is why it is more common. So, and also if there is a background liver involvement or liver damage because of alcohol, either thing, then there are more chances of them getting liver disease. So generally, patient will be cachexic, thin-build, poor nutrition. Patient will have may have fever. Patient may have pallor because of again nutritional uh, uh, causes, and acute weight loss might be visible on examination. When we do the abdominal examination, there might be tenderness in right upper quadrant and right lower ribcage, thoracic area. And may or may not, if the left lobe is involved, patient can present it with epigastric mass. And if the pulmonary involvement is there, then you may get signs of pleural effusion, of consolidation, on the thorax examination.